Okay, good morning. Welcome, everybody. This is the Palliative Care Benefit Workgroup meeting. My name is Nico Jansen, Senior Health Policy Analyst with the Office of the Insurance Commissioner, or OIC. Thanks so much for joining. I know that a few people had conflicts. We'll make sure that they can get up to speed on this meeting afterwards. I'm going to start with a land acknowledgement and then set the agenda for today. The land acknowledgement is that we are meeting virtually from Olympia and Tumwater on the traditional territories of the Coast Salish people, specifically the Nisqually and Squaxin Island peoples. Olympia and the South Puget Sound region are covered by the Treaty of Medicine Creek, signed under duress by the Coast Salish people in 1854. The OIC and Washington state employees respect these lands and tribal sovereignty. We acknowledge the tribal governments and the Coast Salish people living on and taking care of these lands. Okay, as you heard earlier, this meeting and all of our previous work group meetings are being recorded and posted on OIC's website for this work group. So the agenda for today is that we're here to talk about the draft final report that our consulting actuary Milliman, Matthew and his team have prepared. We are exactly 1 month out from the due date for this report to the legislature. And between now and next month, myself, Milliman, and with all of your input and collaboration are going to turn the draft final into the final report and submit it to the legislature. So the primary thing we're going to do today is have Milliman brief the group on what the draft final report looks like, with some emphasis on the actuarial analysis, the cost analysis that's part of that. Then I want to open it up and give a good portion of time for questions, comments, and if you have requested edits at this time for specifics in the report, you can voice those now. After we do that portion, I'll give folks some guidance on giving us written comments and responding to the report conclusions for publishing in the final report. So before I turn it over to Matthew, if anybody did not get the PDF of the draft final report, please let me know. You can put that in the chat or email me. It is not a public document at this time. So since this is a public meeting, we're going to have Milliman share it and screenshot it, but I will send that PDF to you if anybody did not get that PDF. Okay, at this point, I'm going to turn it over to Matthew and Milliman to brief you on the draft final report.
All right. Excuse me. Thank you very much, Nico. Before I get started on the draft final contents and the like, did anybody have any preliminary questions they wanted to run by before I start going in, or should I just get started? I think getting started makes sense, but if somebody had something they wanted to pop on first, let me know now. Okay, let me share my screen. One quick sec. Can people let me know if they're able to see my screen or not?
We can see your started screen sharing.
Fantastic. All right. And is the Zoom okay for everybody to see?
I think you could zoom in a little bit more, Matthew.
Okay, perfect. Zoom one back. All right, so I'm going to walk through a lot of the content that we have. Much of this is going to be content that you've seen before, recontextualized, reorganized a little bit, but most of this relates to the previous 3 reports that we discussed with the work group, with a couple specific things built on. We've added in pediatric projections for members 20 years and under. We've also added a number of scenarios in terms of what happens if we relax some of the eligibility requirements, specifically for adults, because that's the one where there's more money there, as well as the requirements are a bit more complicated. Also, before I get into this, we have discussed the draft final with Nico, and we've gotten some feedback already. There are a few things we're going to be looking into, one of which is for the PEB and SEB membership beyond, excuse me, We want to also be looking at the self-funded section of PEB and SEB. So that's something that we're going to be adding on to this, which I believe is an issue where we've undercounted the overall projections relating to that. There's a few linguistic things that we're working through as well, so we can talk about that as well. But I did just want everybody to be aware that there are a few things that are going to be edited between now and the final, even before we get into some of the group's feedback. But getting into the actual report contents, the introduction is going to be relatively similar to what we have before. The source of this was Substitute Senate Bill 5936. We talk about what the work group is going to be considering. You'd ask Milliman to support this project, and primarily this is an actuarial analysis, as well as a lot of other reporting items that are there to help illustrate what we need to be considering in terms of the potential to introduce a palliative care benefit. We've added a expanded executive summary that the first half of which really just gives additional background as what is palliative care, talking about the shortages of palliative care and the issues arising from them. We talk about the sources of data that we got for a lot of the work that we did, palliative care from BRE, Washington State Palliative Care Reimbursement Summary Benefit Report from HCA, as well as payment reforms to improve care for patients with serious illness, PAXI. Those three documents have informed a lot of our analysis, a lot of our design plans, and that is a lot of the basis of what we've done. Broadly speaking, we have put together an actuarial analysis that models what might this look like if we were to introduce a palliative care benefit for both commercial markets and Medicaid markets separately for adults, members 21 and up, and pediatric members 20 and under. The pediatric benefit is much closer to the current Medicaid benefit. It's much more streamlined. The adult benefit has more complicated rules around eligibility, which we'll be talking about in just a minute. Bottom line is that we were between 9 cents and 33 cents allowed per member per month for the commercial market, and between 33 and 36 cents for Medicaid market in 2027. This is if we model this as the benefit starts on 1/1/27, what might this look like in year one? I do know that one of the considerations, especially on the commercial side, is what might this look like in terms of member premiums? And that would be a little bit more complicated because it would really depend on, does the state mandate a specific level of cost sharing or no cost sharing for this benefit? Barring a mandate, what might plans do in terms of what they might want to impose on cost sharing? And on the flip side, while we do look at this as a pure medical cost, in terms of premium, there's admin, there's margin that goes into that. So rather than get into all of the implications there, which is a little bit of a rabbit hole, we focus this for now on the allowed cost, which is much more defined in the data. And given the size of this, I think this is at least relatively indicative of around the range of what we might expect in terms of premium impacts. Similarly, on the Medicaid side, we would expect essentially no cost sharing. So this would be a true cost to the state, and that's something else to be keeping in mind. We also did look at variation between Seattle and non-Seattle areas. The demographics are different, and excuse me. Also, we've looked at average costs separately in the broad Seattle CSA versus everywhere else in the state, and there are some differences in terms of average cost, and that will have some impact, but it's not a very large impact. Broadly speaking, this is still our range, and we'll go through that in more detail once we get there. We've got a significant amount of discussion around background of palliative care, on staffing issues, et cetera. We have gone through this in previous reports, and I don't believe Shelley was able to make it today. We're happy to answer questions or provide a follow-up there, but I don't want to dwell on this one, given that we have previously discussed it, but this is here based on the work that we've already provided and gone over. We talk about shortages, we talk about staffing, provider training, et cetera. So I'm going to skip all of that unless anybody has a specific question, and please do feel free to provide those questions and we can respond accordingly. After that section, we talk about some of the options for palliative care payment models, one of which is a simple fee-for-service payment model. Basically, all providers bill specific HCPCS codes for their services. Those services get billed, those services get paid. That's exactly how it works, period. The other option that we've talked about, which is the one that we've really embraced here, is what we call the periodic payment model. Basically, what we're talking about here is we are modeling out that there would be what's known as a bundled payment for a member who qualifies for the palliative care benefit that is intended to pay for a full 6 months of palliative care services. We have modeled out what the broadly expected utilization would be, and we have built in an estimated cost based on that distribution of services, and then we have set the palliative care bundled payment to equal that amount. We've also built in a small offset for the fact that there are some services already being provided estimating a very small amount of offset for certain of these services would now be rolled into that bundled payment that the member is already receiving. I'm going to take a quick pause. And does anybody have any questions on that broad background? Carol and Sherry, have I missed a point relating to this discussion as well? If I have, I'm happy to supplement that.
I don't think so with respect to the overview.
So Matthew, I have a question and then we can get
Yep.
to Tim's question. I know a lot of us on this call are not actuarial experts, and we talked through the difference between the quote allowed per member per month and the premium. I think you're going to cover this a little bit later, but could you explain what the allowed per member per month really means, right?
Yes,
Versus
absolutely.
the premium.
Yep. So the allowed dollars, what that really means is here's how much is going to get paid to medical services providers. So that could be, in broader sense, that could be the doctors, that could be the hospitals, et cetera. In this sense, it's going to be whoever receives the bundled payment. This is the amount that they are taking in. Again, this in practice, this might be entirely paid by the state via Medicaid. In terms of a health plan, it might be entirely paid by the health plan. It might be something where, in order to qualify, there is a specific member cost sharing that would be funded. That would depend on how the state designs the benefit requirements. It would depend on individual decisions by plans and by stakeholders. But what we are looking at is here's how much the providers are getting paid. And then it's just a matter, and converting that to premium is you reduce some for any that members are paying in cost sharing, because obviously you don't have to double pay for that, and then increase for any admin and margin that different plans may have in terms of constructing their premiums. Since every plan is going to have a different amount of admin percentage and margin percentage, and that by year, there's a bit of noise in there, just like there's inherently a bit of noise in terms of sorry, I just want to turn that off so you guys don't get there's inherently noise in terms of how much cost sharing may exist for individual plans, in not only individual carriers, but individual plan options. For instance, on the exchange, you will see variation in terms of metal levels, et cetera. So we can talk through that in a bit more detail if it would be helpful, but that's broadly speaking what we mean by allowed and how that relates to premium.
So Matthew, thinking about this from the perspective of, either the OIC as a regulatory agency or maybe more importantly, the legislature, right? When they're looking at this, what's the best way to characterize how that affects premium? And would it be accurate to say something along the lines of, even though the allowed per member per month is not the same as a premium impact, and the premium impact would have all these different factors, they're correlated, right? The allowed,
Yes.
what we're paying, what payers are, plans or Medicaid is paying providers is going to, at least for commercial health insurance, is going to end up in premiums, right?
Yes, that is right. It's not a perfect one-to-one relationship, which is why I gave that additional context, but they are very heavily correlated. And I think you can reasonably look at this as the allowed amount is going to be in the ballpark of what the premium impact would likely be, but it's not going to be a perfect match. In some cases, it may be higher. In some cases, it may be lower.
Great, thank you. Jim had a question.
Mm-hmm.
Uh, um, if this is not in scope for the work, that's okay too. But as I was reading through the report on the staffing component of it, and I sort of got to the part of like how much this might cost in a year, um, I think the numbers are somewhere around 7 million or 10 million, depending on the payers. For an entire state, that amount of payment to clinical delivery providers worried me that you'd actually be able to staff the team to meet the needs of the population we're trying to meet. And so I wondered if there's a place in here where modeling out what it costs to staff a couple different models, if that should be in the report, because legislators are going to ask that question too, or if that's sort of outside the scope and that was a decision you all made to not include.
So
That
I
makes
would say
sense.
that, yeah, excuse me. I would say that is somewhat outside the scope of the report in terms of, if the question is how much would it cost the state to build up staffing such that you've got full coverage throughout the state, how much does it cost to, encourage folks to hire? How much does it cost to build up capacity? That is outside the scope. What I would say is that we have considered that one of the challenges in terms of creating this benefit is having enough staffing throughout the state, making sure there are enough providers. One of the things we've done is we have an overall adult take-up rate of about 15% and pediatric take-up rate of 8%. And what that means is basically of those relatively small number of members who are eligible for this benefit, we are assuming that 15% of them would actually use it. That's based on a range of historical utilization patterns that have existed from various sources and what we consider to be reasonable. Part of what likely goes into that is that you aren't likely to see full staffing availability everywhere, that you may start to see some difficulties, especially in year one. And that's one of the reasons we do note that over time, as the benefit is better understood by both members and physicians and other providers, as you start building up capacity, we would expect the take-up rate to naturally be increasing over time. But to your direct question of if the state chooses to actively and directly fund an expansion of staffing capacity, we don't have a specific estimate of how much that would cost beyond here's how much it would cost to provide the services, assuming that capacity is there.
Yeah. Okay. That's helpful. Thank you.
We've certainly considered, I think, the issues in your question about how adequate is the workforce, and if you create a benefit, will there be providers? Our mandate is to consider the staffing in these various components, but like Matthew said, I think it's a little bit outside what we were able to do for this study to delve into studying those workforce issues in more depth. I think we're looking at it in the context of the cost analysis.
And I might also note that assuming this benefit, in the event that this benefit does become reality or the benefit mandate, some of the capacity would likely be built up outside of the direct intervention of the state, where providers anticipating that they would be able to provide some of these services may start staffing up, and that the cost of such a ramp up would essentially be indirect to the state in terms of that's going to affect the take-up rate, that's going to affect how much gets charged for utilization of these services, but how much of that becomes the state is directly impacting this versus individual providers anticipating this benefit are directly ramping up for only indirect costs. Again, that's a fairly complicated question, and I wouldn't want to make a specific prediction on that one.
I know Drew has a question in the chat. However, I'd like to see if Jim or Chris wanted to speak further to this staffing conversation before we move to Drew's question. Jim, did you want to say something else with your hand raised?
If it's okay. And I may be a little concrete, but I think one of the numbers was like, this will essentially generate $10 million for service delivery. If you think a nurse costs $150,000 a year salary fringe, that's 66 nurses for the state. And so I'm just wondering, like, not even the ramp up, but like, is this going to cover the need? And again, I don't want to diminish like the work, and I don't want to, I think it's important to model out like, this is amazing, we're working on this and we're responding to a request. Is this actually going to cover the cost of direct services? And again, it's not a one-to-one, we're creating totally new jobs, so they'll build on other stuff. But I just wonder, like, is there some workforce cost predictions, not even the ramp up, just like, what will this cover for the state? And again, it's probably out of scope, but that as someone who does clinical operations, I looked at that number and I was concerned.
Yep. No, I mean, I think that's an excellent question as well, worth considering. It's just whenever there's any kind of analysis along this vein, there's some restrictions on what can reasonably be modeled and considered, because we are still basing this ultimately on data that's available and I think your point is valid and your question is valid. It's just giving an accurate answer on that in the event that, for instance, the state is actually paying for it would be significantly speculative. I'll also note that the palliative care benefit is going to, in practice, be provided by more than just RNs. It's going to be provided by a broad mix of providers. So it's not, for instance, that only RNs are going to provide this service, and that's the only potential limitation. There are potential flexibilities around who is going to actually provide, and that's also likely to be one of those decisions that the state is going to have to consider in the event that they move forward with this, in terms of who can actually provide various benefits, from RNs to doctors to clergy, et cetera, because that's the clergy more on the spiritual care side, but there's a range of providers who do provide, sorry, I keep saying providers, provide palliative care services. And I do want just to be thoughtful about the broad range of this, and it is more complicated than just purely an RN question.
Yeah, I picked that as a sort of middle range salary. Doctors would be more, social work would be less. So just to be sort of back a napkin, but agree with you. Okay, sorry, thank you.
I just wanted to add, and this may be really more for the Medicaid side of things, but I think we want to push or at least recommend to the legislature that they include language about actuarially sound rates and some sort of reconciliation project if they decide to move forward with this. So there's a prospective look forward. Here's what we think this is going to look like, and there's lots of assumptions that are in here. And if they move forward with some sort of benefit or mandate, they'll have more assumptions, but let's also include an opportunity to look back and say, well, some of those assumptions were wrong. We thought it was going to be 10 million and it turned out it was 20 million, or, we thought we needed 66 nurses and providers ended up hiring 166 nurses, or whatever it is. I think it's wise for the ledge just to say explicitly, if we're going to do a program, it needs to be actuarially sound. And when you start something up, you need to go back and reconcile and make sure it was okay. Otherwise, if there's a shortfall and there's risk that's being taken here, and by risk, I mean somebody's going to be underpaid, you're just going to get a bunch of fighting between insurance companies, the state, and providers. So let's just dodge that bullet in advance and say, make sure this whole thing's actuarially sound. And after a year or two, we look back and we make everybody whole.
Yep. I think that's a fair point to raise. I mean, the question of who is made whole given shortages is obviously outside that's a policy question, but I do think making sure that we are clear about this needs to be actuarially sound. What we are doing here is modeling what a benefit may look like, the actual benefit that the state may impose, may be somewhat different, may be significantly different, and the numbers we have here solely based on just what the state decides in terms of benefit structure, eligibility, et cetera, may be different, perhaps significantly so. By the time this actually would come into fruition, we would have, there would be in existence additional data that could be used to refine this. Insurers are going to have their own estimates, premium impact, et cetera. But I think that's a very fair point that ultimately we do want to make sure that in the event that this moves forward, that rates are actuarially sound and that we are considering all of these issues.
I think it's just an important thing to explicitly state in this report to the legislature so that they can include that language and, whatever they decide to move forward with, just explicitly state, hey, this needs to be actuarially sound. You need to think about both prospective and retrospective adjustments to make sure you don't have some sort of fighting throughout our healthcare system in case some of our assumptions and estimates were incorrect.
Yep. I think that's a fair point. Did anybody else have their hand raised or additional questions on this point, or should we keep moving forward?
I would just be interested in, it sounds like we have some folks that certainly would want to make that edit, and I do think it makes sense to me, but this is also something that the healthcare authority would be in the driver's seat for operationalizing a Medicaid benefit, right? And I think working with Medicaid MCOs on that. So I think this is something, and I think we have a call separately with Heather and Jamie and their team. But anyway, this edit makes sense to me, but I also want to, see what the HCA thinks about it, either now or Jamie and Heather on our call separately, which I think is later this week.
Well, I hope the HCA would never say, let's have actuarially unsound rates. I mean, that to me, this
I
is
can certainly say that.
This is like an assumption that I think everybody would say we need to do this, and I'm suggesting instead of making it like an implied or inferred thing, let's be explicit and say let's from this committee standpoint, let's make sure this is on the legislature's mind for something that they want to have in whatever bills they pass.
Yeah, I think that's a fair point. And I was just taking a look at the chat. I think Drew had a question about, what the nature of the payments are. I would say that whether payments get trued up in some sense, or whether this is, you get the bundle and sometimes the costs are higher, sometimes the costs are lower, that would really depend on benefit and modeling and policy decisions. For now, what we have modeled is this is a flat bundle payment, and that this would be expected to cover the overall cost of the benefit. There are certainly ways to make a benefit design whereby you do have some level of true up, where the risk goes back away from the providers. Similarly, on the other side, you could have a benefit model whereby the providers are taking on risk, the palliative care providers are taking on risk, not just for the palliative care benefit utilization itself, but overall total cost of care. I know there have been discussions around cost savings, et cetera. Again, assuming that sort of a structure is outside the scope of what we are engaging with, but there is certainly potential for additional models to be considered, to be put into place, either because all of the stakeholders involved prefer that, or because the state mandate says this is the way we want you to do it.
So Matthew, it's more of a straight cap, not linked with incentives. And it's kind of what it is. Okay.
Yeah, I mean, it's essentially a straightforward bundle payment.
Yeah.
And there are certainly many ways to design bundles, but this was a straightforward one, and other options are on the table potentially, but we had to pick one.
Yeah, wondering if there's some impact to, have some outcomes and or quality and or whatever associated with that bundle and how that got trued up. But okay.
Yeah, no, I think it is very possible to design something where you're explicitly incentivizing certain quality measures, where you create some sort of regime. There are many other bundles where that is the case. It's just designing that would be outside the scope of coming up with a broadly reasonable estimate of what this may cost. But that also goes back to actual soundness. If they want to design a more complicated bundle, if they want to build in certain incentives, you'd want to make sure that any kind of cost projections would reflect whatever those decisions might end up being.
Yeah, okay. So my only concern is, and it's written in there, is that, with a fixed reimbursement model like that, you can have underuse of services. And I was just wondering what protections might be there, to be able to have oversight of that and make sure that, whoever the palliative care provider is not getting, is providing the services that are part of that bundle.
Yeah. And I think monitoring is probably part of that in practice. I would say one of the considerations here is that we put in a take-up rate of the members who are actually using the service. That means that there are a lot of eligible members where no payments are made because they're not using the service. So that by itself is an assumption that this isn't going to be anybody who's eligible. The provider gets paid multiple thousands of dollars, whether they do literally anything or not. That's only a partial protection, though. I think in practice, you are going to want to have some level of monitoring and structure to make sure that you don't get any problems. Carol or Sherry, do either of you want to comment additionally on that question? Because I know that you've seen some of these in practice, so I don't know if I've missed something there.
Yeah, I think there are a variety of ways, as you've mentioned, to deal with a bundled payment. Sometimes it's a fixed payment with the understanding that you meet medical necessity for patients, you do some monitoring, and for some patients, essentially your payment is more than the cost of the services provided, and other patients is less. In other cases, there is a true up afterward. Now that true up afterward can be complicated because it means you have to have billing codes and you have to have like the information available in which to do the true up. And that can be a lot of administrative work also. And arguably, I think from some of our experience, can promote overutilization of services, right? So there's that as well. So I think these are all part of the decisions about the payment approach. And again, we've taken a relatively straightforward. There are a lot of services that are paid in various markets based on an episode basis, including home health and Medicare, for example. And there's no true up that occurs, and some patients require more, some patients require less. There's some risk adjustment that occurs. The other possibility here is to more fine, you could go after, if you were not going to do a true up, sort of a more granular segmentation of patients that customizes, I'll say, the payment amount to the expected needs of that patient in a more granular way than the two split that we've done here, sort of this like simple and complex level. So, but again, these are sort of decisions made about like what you want to accomplish with the program, how much administrative resources you have to carry this out, what kind of incentives you want to create, what monitoring are you able to do.
Thank you, Carol. That was helpful. Heather, I think you also had your hand up. Did you have a question for us?
Yes, I have a question about what services we are talking about when we talk about the bundle payment. Like, are we talking about community-based, not in the hospital services? Because as you were like talking through, you had mentioned like hospitals could be paid or clinics could be paid, but those seem like two different.
Yeah, sorry, I was talking about that in more broad sense of like what is an allowed amount, like in terms of how to understand that, as opposed to this is necessarily a hospital type situation. You know, these are the services we are talking about, which are expected to be primarily non-hospital type services,
Yeah.
through physicians, through nurses, through clergy, through social workers, et cetera. But
Right.
this was the table, slight bleed out on the second page, that builds out the specific services that we have talked about, including in the bundle for adults 21 and over, and we've got listed elsewhere what we have for kids.
The
Yeah,
reference
I think it'll
documents
be,
that create this, I'm just saying, are built on what are community-based palliative care programs, right? These are
Yeah.
not focused on palliative care in the hospital setting, as an example.
I think that should be called out specifically, just for clarity. I think people who are familiar with palliative care could sort through that, but if you're thinking about a legislator reading this, they don't know necessarily the difference between a palliative care consult in a hospital and an inpatient setting versus what we are driving at here with this report. So I think a little clarity around that we are talking specifically about community-based palliative care services would be helpful.
Yep, we're happy to spell that out and just make sure that's super clear. And thank you for raising that point. Did anybody have any other questions? I want to just make sure I don't skip over any items. We talked about the payment model, linking. We had some discussion about, there could be links to quality and value, et cetera. We talked about next section, Heather, by the way, did you still have your hand up, or was that just a holdover from previous? Thank you. Just wanted to make sure. We talk about evaluation criteria and reporting requirements. We reorganized this slightly, but this is similar to what we've been talking about before. We did add some discussion around requirements for pediatric 20 and under, but these are broadly speaking the language that we'd had before. Similarly for clinical eligibility criteria, services included. We put some of this into the appendix also just because this is already a lengthy report and a lot of the really detailed data, we didn't want to sort of drown this out. We wanted to make it a little more readable. So we did move some of the things onto the various appendices just to help with flow and readability. In terms of what we are expecting, we gave an exhibit of these are the assumed services per 6-month adult episode. One of the specific questions that was raised is what exactly do we mean by caregiver support? There were some HCPCS data that we used there, but basically the key point and why the average cost per service or per unit was so small is that this has tended to be an add-on service during another visit or service that's being required. So for instance, this is an add-on during an E&M visit where the additional cost of the caregiver support assessment is very small as compared to the overall cost of the visit because it's only one part. That's one of the reasons we had a relatively low number there. But this is a breakout of what we are expecting in terms of the distribution of services. And again, we have split this by tier 1 and tier 2, tier 1 being relatively normal episodes and tier 2 being relatively complex episodes, people who have more serious functional status limitations, and so on and so forth. And then we also had a breakout for pediatric. Again, this is a much smaller list, but there's a significant amount of services on average per, but the cost per service is smaller for pediatric, just given the overall nature of the design. One really important thing we wanted to just call out again is that we are assuming a notable minority of members who are eligible would in fact use these benefits in 2027. 15% for adults, 8% for children. This is a number that we would expect to increase over time, and the scale and the curve of that increase is a little bit unpredictable. A lot of it would depend on, how much we start to see staff up, how much, regular physicians look at this as, yeah, this would be beneficial for our members. What level of member acceptance do we have? Because a lot of palliative care benefits haven't always had high take-up rates for various reasons, and they haven't been popular with the members themselves. But as this benefit becomes more established, we would expect that you'd start to see a ramp up to whatever the natural equilibrium point is, where some of those other issues start to become dampened. We don't know exactly what that's going to look like, but it is an important consideration for a longer term projection that the year one numbers aren't necessarily going to stay forever. We would expect these costs to go up as time goes on. Broadly speaking, let me just go here and note that this is our overall estimate of cost. One of the points that was raised by Nico and others about PEB and SEB is that there's also a significant number of PEB self-insured, and that's why the actual PEB and SEB membership is significantly higher than what we have here. We are in the process of updating our projections to account for this, and we will be revising our tables when it comes to the final report. Just wanted to make an explicit call out that we are in fact looking into this. The other point I wanted just to call back on is we do see some variation in terms of the overall cost by line of business, as well as by in Seattle, out of Seattle. For the most part, there wasn't a really significant difference between the Seattle and non-Seattle per member per month values. We actually saw that outside of Seattle is a little bit lower for Medicaid. I think that was largely driven by different demographics. We did see for the individual market specifically, the non-Seattle was significantly higher than Seattle, but for the most part, they've tended to be pretty close. In aggregate, right now, we've got a little over $10 million for the total expenditure. Again, that's in an allowed amount, so cost sharing that members may pay might be reduced for that. Admin and margin, if you're looking at a premium impact, may increase. So that's not going to be a pure, here's the total cost to stakeholders, but it is a starting point for that discussion. We're looking at in the ballpark of 25 cents allowed per member per month, which is not trivial. It's not like it's a penny, but it's not a extremely large amount either. So the question of, is this too high? Is this acceptable? That's a policy question that's outside the scope of what we would opine on, but we are attempting to give a reasonable estimate of what this may look like in practice, with the caveat that we're going to be adding in an increase for PEB and SEB self-funded. I'm going to take a quick pause and ask if anybody has any other questions. So Marcia, I think you just asked, does the bundle payment replace any current fee-for-service billing we are being reimbursed in the current models? Yes, to an extent. So we are expecting that this bundle would basically be paying for the palliative care services for these members. There may be palliative care services already on offer in some cases for members outside the scope of this particular benefit. So those would not have any sort of an offset. But we actually have built in an offset for these specific members, looking at some services that could be realistically rolled into the bundle. We have made a downward adjustment to account for that so that we wouldn't be double counting services. I can actually show you what that looks like. Just give me a quick sec. A lot of appendices, so hold on one sec. So for instance, when we look at, let's say, Medicaid outside of Seattle, we build up the tier 1 and tier 2 utilization per episode, how many you have on each, and then also look at pediatric. And then we say, well, what is the cost of services overlapping the benefit? For some of them, they're really, really small. This is $7 out of a 3,500 bundle. For some others, those numbers are a little larger. On the commercial side, it's more like 25 out of 5,600, or in this one, 52 out of 5,400. Again, we do see variation on Seattle, non-Seattle commercial Medicaid, but in each of the cases, you're not really looking at a very large offset, but it is still something of an offset, and we have considered that. I'm going to scroll back up to our overall results so I don't get lost on this. Gonna take another pause. Did anybody have any other questions before we start moving on to a couple of the other points?
I think this is a pretty important chart in the grand scheme of this report, as we've discussed, Matthew. So, you know, let us know what you think, everybody. And also maybe what people formulate questions or concerns that they want to state on this. I'll also say, I'm not sure, Matthew, if you mentioned this, but the OIC, myself and Jane, requested that Milliman account for services, basically palliative care services that are already being covered and reimbursed in this model. And my understanding is that that did result in a slight change in the PMs you found in this product, in this table you're looking at versus what Milliman had originally done.
Yeah, that is correct. The other difference between this table and what we'd had in previous versions, and Marcia, yes, this table should be on the draft report, PDF page 20, suffix page 17. You know, again, you've got a couple title pages on there. So you should be able to track this. One of the other difference I just want to be explicit about here is that this table is on a basis of all members, both pediatric and adult combined. Our previous analysis was purely among the adult population. So now that we're looking at the broader population, the per member per everyone month, those numbers are smaller, but the population is larger. So net, you do see an increase, but that is something else that we have been adjusting to account for that. Anybody have any other thoughts or questions before I move on to the next section? All right, so we also the next thing I wanted to talk about is the scenario testing. One of the big questions that arose in workgroup discussions, as well as what we were considering overall, is what happens if this is a less restrictive benefit, specifically in terms of eligibility criteria. So what we've basically decided is that in our original model, adult members in hospice are not eligible. Unplanned hospital visits are a requirement. Functional status limitation is a requirement. What we looked at this and said, well, what if we relax some of those requirements? So we said for alternate scenario one, what if we no longer have any functional status limitation requirements other than we do use functional status limitation to separate tier 1 and tier 2. So tier 2 would be exactly what it is, but we would have a much broader base of members who would be eligible for tier 1, which is the more moderate level severity. Alternate scenario 2 is what happens if if we no longer require an unplanned hospital visit. And then scenario 3 is what if we relax this hospice eligibility? As you can see, and I'll scroll back up just for comparison points, the impacts of these are pretty significant for scenario 1 and scenario 2. And in fact, if you were to, for instance, combine scenarios 1 and 2, you'd see even more significant impact. We have seen a relatively light impact on the hospice requirement. And I want to caution there because this was a pure what does the data tell us calculation. In practice, given more utilization of a hospice benefit, we might see more members transition to hospice earlier. It's possible there's some data missing from APCD, et cetera. So I would just throw a little bit of a cautionary note when looking at scenario 3 in particular. I would normally expect that the value of that hospice exclusion would be more significant over time. The other point is that in practice, there may be adjustments to the bundle for a member goes into hospice in in month 2 or month 3 of the episode. Should the bundle be adjusted for that? What might that look like? That specific model is outside the scope of what we've been projecting out, but those are also considerations that are important for the overall cost of the benefit. Depending on how that's structured, that could result in additional reductions to the overall projection. But again, it really depends on how that's defined and discussed. The other point I wanted to raise specifically is relating to redetermination. So what we've basically modeled out in our base case is if a member is eligible for this palliative care benefit, they get a 6-month episode. When that's over, they need to be reevaluated for eligibility on every requirement. So if, for instance, they no longer go to the hospital at all, but have all of the other issues, they may still be eligible for the 2nd episode. They may not for the 3rd episode, depending on the overall timing. One of the things that may be important to consider here is whether or not whether or not the state chooses to relax some of the requirements, not necessarily for everyone, which is what scenario 1, 2, and 3 looks like, but specifically only for redetermination for some of those longer term members who are going to be there for multiple years, as opposed to those who are essentially a pre-hospice type scenario. That precise impact is fairly challenging to estimate and gets outside the scope of what we're looking at. But I did just want to consider that you're going to, in overwhelmingly likely scenarios, be looking at something between 25 cents and 45 cents for the total cost if you were to remove functional status limitation just for redetermination, between 25 and 39 if you removed it if you removed unplanned hospital visit just for redetermination. I think those are important decisions to be considered by the state. And I did want to call that out specifically because there would potentially be an impact, likely materially smaller than relaxing it for everybody, but not necessarily zero. I'm going to take another pause. Anybody have any other thoughts or questions before I continue moving on? All right, so what we're laying out here is a lot of similar detail. We've reworded it a little bit to try and add clarity here and there, but this is pretty similar to the information about approach we've previously discussed. Again, we are moving some of this information into an appendix just to make it a little bit easier. One of the new items that we've added to this version is having Washington enrollment projections, which are based on existing projections that we've rolled into here. We made an adjustment to Medicaid for the impact for some of the projected impacts from Kaiser Family Foundation, et cetera. So that is why we no longer only have values in PMPMs. We have total members, total dollars as part of our projections. Beyond that, we've restructured how we're describing our eligibility. Broadly speaking, the eligibility is, again, this is for adults, identify people with serious or chronic illness, exclude members in hospice, only include members who have unplanned hospital visits and functional status limitation. Again, these are 2 items which we have relaxed in our scenarios, and to the extent the state might want to either eliminate those requirements or adjust those requirements, there could potentially be cost impacts, and it would really depend on what exactly this state would consider. Similarly, if the state wanted to increase the number of serious or chronic conditions that would be eligible for this benefit, that would have an additional impact, and it would really depend on what specifically they wanted to do there. After that, we basically say those members have palliative care episodes, and then we say, well, how severe are their functional status limitations? That makes them tier 1 or tier 2. Tier 2 has higher utilization projections, higher bundled payments. And we gave a overall projected eligibility rate per 100,000 members for tier 1, for tier 2, and then for pediatric. And as you can see, these numbers are relatively small, but not zero. And that's why this along with the take-up rate is the big reason why you see overall PMPMs that are relatively small. It is costly per episode, but the fraction of the population that's going to be eligible for this isn't going to be enormous. And the fraction of those eligible who will actually use it, again, aren't enormous. We talked about take-up rates already, but there's a number of different sources that talk about issues with take-up rate. In particular, which is new to the discussion, we had seen multiple sources that talked about pediatric take-up rates tends to be significantly lower than adult take-up rates, so we have adjusted for that. But even on the adult side, you can see significant variation in the number of beneficiaries who use it, noting that a lot of these benefits aren't one-to-one comparison with what Washington's considered, but we saw a NASHB example where you're looking at 35%. Medicare Care Choices was under 1%. So you do see a significant range. If you get less than 1% take-up rate, the actual cost to the state and stakeholders would be significantly less. If you were to see a year one take-up rate of 35%, it would be significantly more. That's not necessarily the range bound of what's possible, but those are some of the ranges of what we've seen in practice. And again, we would expect that over time, that take-up rate is going to increase. It might increase rapidly, it might increase slowly, but it would likely increase materially over time. Otherwise, we've also looked at development of unit cost by service. I'm not going to dwell on this one since we've previously discussed it, but this information is there. Again, we've reorganized it slightly to be a little bit easier to follow, but that's all part of what we've got. I think the other item that's likely of interest to this group is the discussion around potential cost savings. We've looked at a significant number of sources. We've listed a few of them that we've looked at, but this is by no means the whole list. I know that we have been forwarded certain additional sources, some of which we were not able to independently find in the public sphere, but those were also part of our review. Right now, we specifically cited things that are specifically in the public sphere, but we have looked at more than just that. One of the things we've basically found is that while there may be evidence of savings in many of these studies, those studies aren't necessarily one-to-one aligned with what Washington is considering. Rather than go through individual source by individual source, I think that becomes fairly tedious and difficult to follow. We've talked a little bit more in terms of broad strokes of some of the limitations of the studies we've seen, talking about why we aren't necessarily applying a 20% savings there, a 30% savings there, or something like that. One of the big limitations that really jumped out at us is many of the studies we've looked at really are focused on hospice, and this is a non-hospice benefit. I think one of CMS's studies noted that half of all of the savings they had seen was because members are transitioning to hospice. One of the others is that many of the studies that we've looked at are specifically for hospice populations, and hospice populations have significantly different cost and utilization characteristics than a non-hospice palliative care benefit population. In particular, you would naturally expect that the amount of utilization for ER and hospital for people who are in hospice are going to be significantly less because they are in hospice, as opposed to the nature of the care they're receiving there. So I do think that that is one of the major restrictions to trying to take some of those sources and apply them here. We also have seen significant population differences. Many of these are Medicare or end-of-life populations. There's credibility concerns. Many of the studies we've looked at have very small populations. That's not a flaw of the studies themselves. That's a flaw of the nature of what is being looked at. It's very challenging to find a population that is large enough to be truly robust. Perhaps the biggest attempt at that was the CMS model, where in the end they also had credibility concerns because the take-up rate was so small in what they tried to look at. It's a concern. We've also seen some instances where we would look at cohorts. One example looked at, again, it was pretty small population size. We had Medicaid, Medicare, and commercial, and there were massive differences in the overall rate of savings, with Medicaid being a negative savings and increase in cost, Medicare and commercial being significant positive savings and significantly different percentages from each other. when we observe things like that, particularly when there's no particular hypothesis that says it should be in exactly this ratio because of this, and that's part of the study design. It's just, hey, we've seen really large differences. I think that adds concern about credibility of results and concern that a significant amount of what's observed is variance. In many cases, there's been a relative lack of documentation around study details. In particular, obviously certain things are obvious, like what population was looked at. Was there a control group, which some did, some didn't, some were silenced. Also, in what way have people looked at differences on reversion to the mean, in particular, any other issues that could potentially look at this and say, this study showed a savings, but that savings isn't necessarily applicable to something like Washington. We also saw benefit structure. One of the big ones, and I wanted to highlight this again, is reversion to the mean. Many of the studies we've looked at basically said, here's this population, they've joined this program, look at these savings they got in year one. A lot of these members are joining these kind of programs after high cost, high utilization events. In many of those cases, even without any palliative care specific, any particular intervention, you would expect these members to see lower costs on average. There was one or two studies we looked at that had a control group and an intervention group, and they saw really large savings on the control group, and it was just, oh, that's interesting. And I think that's a good example of active evidence of reversion to the mean. I think this is one of the really big ones. This, along with selection of members who are choosing to join a palliative care or hospice program, have different characteristics, different intentions of using benefits than members who may not. And I think that's another issue that could potentially bias this. But basically, between all of these, due to all of these different concerns, we looked at this and said, we believe the most appropriate and supported assumption is to assume zero net savings, no increase or decrease in medical costs for ER, inpatient, et cetera, due to the existence of the palliative care benefit. Though the cautionary note, again, because we love cautionary notes, is just because there isn't strong evidence supporting savings for this program, that doesn't mean that there is strong evidence of there being no savings. There are studies that suggest there may at least be the potential for offsets, potential outright savings. HCA did a reimbursement project in 2023 that had some studies quoting them. And they also noted, it's going to depend on eligibility, how close is the service model, other barriers like workforce constraints, et cetera. It is very challenging to be able to say this particular study would be relevant. We saw 25%, let's say, reduction in inpatient in study A, therefore we should assume 25% or something like that. I would say that it's important to keep this in mind, that zero is the assumption that is most supported based on the evidence at hand. That does not mean that zero is the exact right answer. There may well be savings. We think it's prudent on the state's behalf to not necessarily assume savings, especially significant savings, but it is possible that there will be savings and that this would be realized. Carol and Sherry and Casey, did you want to supplement my discussion? I may have missed some points that you wanted to talk about on this issue in particular.
No, I think you covered it, Matthew.
Okay, and then I'll come back to this because I'm assuming we may have more questions. We talked about certain considerations and limitations. We are going to add a couple more things in here, but these are some broad limitations. We talked about, there is no current benefit mandate in the commercial market. We did observe some utilization of procedures that could be overlapping. We removed those. We talked about that earlier. one of the big ones is our eligibility rates are based on claims data from the identification of functional status limitation, et cetera. In practice, you may see materially different eligibility rates based on whatever the requirements the state may have, like electronic health record documentation. Due to however these requirements may be imposed, you may see significant different eligibility, which would create significantly different cost profiles than what we've projected. The actual benefit may be different. Ultimately, we were looking at 2022 members. Greg, thank you for that note. We'll consider that. I want to be cautious about anything we say here, but we'll take that suggestion in mind and discuss that. I don't want to give a quick snap reaction to that, but we are definitely going to be considering that feedback.
Can I add something to that?
Of course.
Okay, so, and I know, Greg, we've talked individually with you and been emailing. I do think this is really a central point in, basically a disagreement that I've heard expressed from Leslie and Barb and Greg. And I think the challenge with that kind of broad statement in the executive summary is that Milliman's cost analysis does indeed project the per member per month increases. Right, Matthew, rather than assume that, in other words, the analysis that Milliman has done here does not conclude that the benefit would be budget neutral. Is that a correct statement, Matthew?
Yes.
So I'm speaking for the OIC in convening this work group. I don't want to put a statement in the report that is that definitive. If indeed the analysis from Milliman is that. And that's why I think we can have the discussion in this report about cost savings, and that just because Milliman did not find sufficient evidence to assume cost neutral, right, or cost savings doesn't mean that it's not possible, right? And then the other thing I'll say, and I'll state this at the end of the meeting and put out a reminder to everybody, but we're, accepting any work group members' written response, including if that's a disagreement with the results of this analysis. And we're going to be, if you want that published in the report as kind of a response or dissenting opinion, we're going to be doing that. So that, your voice is part of what's going to the legislature. So I really appreciate that point, Greg. And I just think that's where we are in it right now. Okay, yes. So, and you can chime in here, Greg, if you're able to. I know you have some clinical duties. Let's work with you to make sure that all of the various statements are as consistent as possible. That I can promise.
That sounds good, Nico. And like I said in the comment box, I'm not pushing for any statements that don't 100% accurately reflect the reality of your analysis.
Right. I think you had read it with Leslie and Barb and said, we think some of the various statements are kind of contradictory or inconsistent. Let's work with you and Milliman to look at those statements. I think that's kind of a different thing.
Sounds good. Thank you, Nico.
Okay.
Yep. And thank you, Greg, for bringing up your comments. I want to, I think at the end of the day, we have a disagreement about the conclusion, but that doesn't mean that we think that your take on this is unreasonable or anything like that. It's a professional disagreement, and those happen. Does anybody else have any comments or questions? I think we've got about 20 minutes left that's budgeted. I'm happy to talk through whatever else may be on people's mind, if there's additional, whatever that may be. Heather, I think you have your hand raised.
Yes, I had a question about pediatric eligibility, which excluded kids who are getting private duty nursing or home health. And I know that in a previous work group meeting, it had come up when we were discussing what the existing Apple Health benefit looked like. There was some confusion around that piece. And I wanted to make sure that that confusion wasn't still being carried forward. The distinction is that there's not double dipping. So somebody who's already getting home health services isn't going to be able to bill palliative care for the same service. But I don't think we would want to exclude kids that need private duty nursing or home health, which sort of by definition would be the medically complex kids that you would imagine
Yeah.
would benefit from a palliative care benefit.
I think that's a fair question. Carol or Sherry, did you want to weigh in on that? I didn't have an answer to that off the top of my head, unfortunately.
Hi, Matthew. I think this is, excuse me, one of the points that we had revised the analysis plan to ensure that pediatric members that were receiving home health, hospice, or private duty nursing were still eligible for the benefit. So we can circle back and make sure
Okay.
that they're included in
I'll
the
double check. That may simply be a typo in our discussion.
Okay, thank you.
And if not, that'll just be a revision of results. We'll validate that and make sure we're accounting for it in the final one way or the other.
So thank you, Matthew and the Milliman team, for the hard work on the draft final and for presenting it today. As I'm not hearing other questions right now, let me interject to give everybody some guidance on our next steps. So I just pasted some information in the chat so that you have it written in an email. And this is, I think, pretty much what I have sent out in my previous emails. It just has some of the dates filled in. And Matthew, I think that those dates are basically what we've discussed. So, and let's chat if, we need to alter these. So basically, I think we sent this draft final document about a week ago, and if you have additional edits you want, you can certainly do it in terms of like quotations at the level of a sentence. Please send those to me as soon as you can, but I think October 8th or so is, when we would need to have those in order to consider them and make substantive edits to the descriptions and statements of the report. So that's one item. And then, as I mentioned, in addition to requested edits, this is more on the cost analysis. If any work group members, their organizations, want to do a letter that is included in the appendix to the report, please send those to me. And because we're just going to stamp those or put them together at the end of the report, you have a little bit more time to do that. And I'll work with everybody to make sure that, what your input is can be included. So I'm giving folks a deadline of October 17th for that, because that's more just OIC putting those at the end of our PDF. Okay. And then last, the OIC is planning to put our own cover letter to precede the Milliman report, and that will be part of what we publicly give to the legislature. And we do that often on reports where we summarize it and, kind of give any perspective from the OIC. Please contact me if you have any questions or concerns. In the meantime, happy to get on the phone with anybody. I've talked to a number of people individually. So that's where we are. We kind of have this month process to complete everything and send it to the legislature. And then I think November 1st falls on a Sunday, so we're determining whether the transmittal would be the Friday before or the Monday after. So we'll figure that out. Okay, any questions, comments, concerns on the list I put in and the dates and what we're asking from work group members? Okay. Great. Thank you, everybody. I'll put this out in another email to everybody with the draft final document attached once again. Please let me know if you have questions. Thanks, Matthew and Milliman. Thanks, Remy, for facilitating. All right.
Thank
Thank
you.
you very
Later.
much. All right, bye.
You can end recording, Remy. Hey, Remy, are you there?